We hear a lot about, oh, you can't work with the feds, and it is true. It's a bit of a cumbersome mechanism, and their rules get a little complicated and so forth, but I've got to tell you that the efforts that Marilyn and her team have made to work with us, support us, and help Virginia get where Virginia wants to go are very, very, I'm gratified that we've had that opportunity, and I want to say that publicly, and I just wish she'd stay to listen. That's all. That's all. Always difficult to follow the entertainment value of Professor Nichols. Professor Nichols, though, has hit on, I think, a lot of very important things, and I want to put them in a little bit of Virginia context. And I know that Beth and Ashley are worried because they put together a very nice presentation for me to give to you, and they never realized, orthopedic surgeons never learned to read, Ashley. So I may have trouble, but I'm going to try it, but I need to take a detour before we get started. I look around the room here and we talk about collaboration, and what a collaboration we have had over the last few years. This is our third health conference. I shouldn't say ours, it's Barry's, and the Chamber has put this together, and Barry and Bill, the recognition that health is critical. We want a thriving economy in Virginia. We want it to thrive. You need healthy individuals for that, and vice versa. You want to be healthy, you need a thriving economy. It's a natural fit. And being able to bring the payers, I'm one of the payers, sort of. I speak for, I guess, Virginia and the taxpayers in that extent, but let's think a little bit about who all's in the room. We have the private payers in the room, the businesses, but every single one of you is also a taxpayer. Don't forget that. You're paying on both ends, so this is important to you. We have providers in the room, our hospital friends, we've got physician friends, we've got the public mental health structure. The CSBs are represented here. Very important that they're part of it, the various providers that come into it. So they're represented. The fiscal intermediaries, the insurers, the Anthems, Aetnas, Optimas, the innovation plans of Carillion, all the payers are here. We're off to a real good start. We have a health information exchange in Virginia, Connect Virginia, that we are trying to get to scale, and we need support to get that to scale if it's going to continue. The Health Information Exchange is represented here today. We have an all-payer claims database in Virginia. You heard Marilyn talk about data. You heard Lynn talk about data. The General Assembly, in its wisdom, created an all-payer claims data built on the efforts of Virginia Health Information. They're in the room today. When I start naming people or naming organizations, I always forget some, but this is the place for this conversation. So what I'm going to, my topic is really a call for action. But I want you to think a little bit about this is where the collaboration starts. It is here. I'm going to tell you a little bit about what we have been doing in the public space and how we have been working with you. And I would like you to remember this. And I'd like you to remember one other thing that I'm surprised it's taken us this long to get to, but there is an election this year. And it's not just for governor and lieutenant governor, attorney general. There are delegates and senators out there who want your support, and not everyone, believe it or not, shares a vision for healthcare that includes this collaboration. And I think it's perhaps appropriate to remind candidates that this is an issue for every one of us in the public and private sector. It is an issue for every single one of us, and ignoring it will not solve it. Now, you heard Marilyn mention that perhaps the PPACA is less than perfect. There's some of us have varying degrees of attitude about the PPACA, the Patient Protection and Affordable Care Act, Obamacare, if you will. Ladies and gentlemen, it is the law. Here is the problem that we run into. It will take an act of Congress to change that law. Yes. Now, we have acts of God in Virginia: hurricanes, tornadoes, swamps, and dismal farms, earthquakes, and snowstorms, among other things. But congressional action this year, does anyone think it's going away? We might wish it was. We might wish people would actually fix it where it could be fixed and where it could be tinkered with, but it is here. And the question is do we want to pretend otherwise? Or do we want to use what tools it provides us and make things work? Or do we just want to fight and say it needs to go away? I personally think it probably needs to be fixed, and maybe some wise people will come together in a partisan fashion down the road and enable that conversation to happen, but it's not likely to happen on our watch. And even with or without the PPAC, we still have the problem of healthcare costs. We don't have the value of the system, the quality. We don't have the access. We don't have the health. And we certainly don't have the cost managed. So we have work to do, and the question is how we're going to do it. So a couple things that we have done. We created the Virginia Health Reform Initiative. It's been meeting now for the better part of 3 years. A number of you have participated in that. The next meeting of the Virginia Health Reform Initiative is next Wednesday here in Richmond, and we will be discussing the Medicaid reform plans that have been put into action by DMAS as a result of the General Assembly's budget. We will talk a little bit about where we are with exchanges and the role of the Bureau of Insurance in doing the plan management function. We have 9 plans that have signed up right now for review for the individual market, 7 for the for the shop exchange. We'll be talking about that. We're going to talk a little bit about what we're doing in technology to support the eligibility functions, among other things, that we have at the Commonwealth, huge undertakings that are ongoing. We will talk a little bit about where we're going with the Virginia Center for Health Innovation. But I want to come to that now, because no matter what we do, if we keep doing what we've been doing, it isn't likely to get us where we want to go. Not even to Mississippi, probably. But the value will come as we move forward, and I think that where we are with health innovation, what I want to share with you is important. And we're going to take you through this, and I want you to understand the template. We don't have all the details yet, but we have a template for what we want to focus on in Innovation in Virginia. This is what we are trying to do with the Medicaid reform. This is what Sarah Wilson, DHRM, Sarah's in the audience, is trying to do with the State Employee Health Plan. This is what I hope our business community is aligning around as we look at what do we need to do next to make healthcare a better value in Virginia. So this is we are. Governor McDonnell in December of 2012 gave me this charge. Gave the Virginia Health Reform, or gave the Virginia Center for Health Innovation this charge, and I share this with you because it is the challenge for all of us. We must change the way we deliver and pay for health care. And it talks about how we work together to do that. It's critical. We created the Virginia Center for Health Innovation. It lives at the Chamber of Commerce. You've heard that some of the partners mentioned, the health plans, the hospitals, the nurses, the medical societies, some pharma. All of you who are represented out there have participated in this as we've gone forward. We have to create a plan. What we would like to be able to do is apply for some of the state innovation model funding through a CMS. We know that you can get up to $60 million for a 3-year period, but that's just one of the opportunities. There are other places that we can go for funding, and there are things that we can do internally. But we want to work to meet the requirements of the state innovation model programs. You notice when Marilyn showed the graph that Virginia doesn't seem to get a lot of that money. That is a problem, and we're trying to solve that by working together through the Innovation Center to have more compelling proposals and to leverage our assets a little better. The innovation plan development has gone around 6 work groups. First, engaging consumers in value. Professor Nichols mentioned value-based insurance design. Can't take you through that today, but how we use the plan design to encourage consumer engagement. We can't redesign the health system strictly on the delivery side. We have to look at how individuals engage with health and with health care. Transparency. heard that a couple of times today. We have an APCD, we have VHI, we will be getting information into the public realm. Now, what do we do with it? I should mention Professor Nichols at the Richmond Times-Dispatch is right here in the front row, and he'd love to put it in the RTD, but it is true, it probably needs some analysis. And so how do we pick out what's important and get information packaged in a way that it is usable for consumers in purchasing and for providers in reorganizing delivery? We talk about, let me just see how fancy this is there. This is the one I'm looking for. You've heard about patient-centered medical homes, and they do work. They do tend to improve patient satisfaction, quality scores. They lower emergency room utilization. There's ample evidence of this. Certain places, Professor has pointed out that it is a bit of a zero-sum game unless we are able to enlist the specialists in payment models that are somewhat analogous. Suppose your issue is cardiovascular disease that's beyond the capacity of a normal family practice. Can we build a model of medical home around cardiovascular disease? But what about mental illness, where we have very significant shortfalls in workforce and capacity and in outcomes already? Can we do this around mental health? If your primary medical issue is a mental health issue, can that become your medical home? And can we find a better way to organize and coordinate your care using these incentives? And then, of course, the ever-present workforce issues. And folks coming into insurance over the next year or so, they're not really looking for insurance as much as they're looking for health care. And we have the whole workforce issues with it. And our workforce has been trained in the old models. I grew up as one of those in fact, they selected us to be fiercely independent 24 hours a day. We can get up in the middle of the night and yell at any nurse anytime. That's our job. And that's been in our training for years. So how are we going to change the training of physicians and nurses and dentists and psychiatrists and psychologists? How are we going to learn to work in teams that's in a patient-centered approach? These are things that we are working on. We have the Virginia Health Workforce Authority, and we are looking at this through our innovation process. And then I've got another one I'm going to come back to in a minute, but we do have to look at health. And a lot of what we do in health prevention, I think, is too late. And introduce you to this concept of pre-C to pre-K, preconception to pre-kindergarten. The business community out here knows, and we've been fighting for education. We want kids to read at grade level in third grade because that is the secret to success in life, right? How long have we heard that, and how many billions of dollars are we spending on education to get kids from first grade to third grade? But what happens when you go to kindergarten hungry? Or what happens maybe when your mother, was a substance abuser, smoker? We know the birth weights aren't as high, the brain development's not there. We're seeing increasing number of people with intellectual and developmental disabilities. We have a horridly high rate of premature births in Virginia. We have infant mortality that's high, IDD increasing. We need to begin to work at getting these folks to the proper setting for care and the proper care earlier. And I'm really pleased that we have a work group looking at how we can innovate around getting women into the medical homes, perhaps for obstetrical care earlier, and even more, how do we create the database that demonstrates it's effective? We do lots of things in government and in healthcare because we have a bias to help. We like to help. We want to help, but I could give Barry, I want to help Barry, so I'm going to give him my glasses. Barry, do you want to try these? I want to help you. All right. Okay, and they work for me, so they should work for you.
It doesn't work.
It doesn't work for, you're ungrateful, Barry. They should work for you.
We should have rehearsed this.
Yes, point being is we do a lot of things because we want to help, but sometimes they don't. Or sometimes the value isn't there. So as we look at how we intervene in these areas, we need to have the data to show that what we are doing actually is effective. Similar theme. We've had over 70 leaders from multiple groups working now through the spring to begin to review the some 370 innovations that have come in through the Innovation Network. And we have several strategic pathways that we are looking at. Number one, we want to see activated consumers in communities. The consumers live in communities. They don't live at work. They don't live at school. They don't live in the healthcare system. They live in communities. We're going to have to figure this out together going forward. And this is a role for business. It's a role for individuals. It's a role for government. We have to look at the care structure, clinically integrated, person-centered, accountable care. Can we pull this together with multiple payers? We have to align the infrastructure, the workforce, and the quality incentives. Professor Nichols has already touched on this in some of the things that we're looking at in a much more memorable way than I could. So 9 action strategies. Patient-centered care initiative, focusing the team around the patient. Prenatal and early childhood health initiatives. Integrated care for physical and behavioral health. Care transitions, the fumble, when people move from one care system to another, still a big problem. And I do want to make one comment just as an aside. Leapfrog Group published some data this year, and our hospitals in Virginia have done a stellar job in improving patient safety. Sentinel events are down, patient safety incidents are down, and I would encourage you to visit the booth out there and get the data. We are one of the best in the country at reducing the errors in the hospitals, but we have to do better when they go from the hospital to the community setting and vice versa. The transitions take detail. Medication management. We have lots of great medications that work, but it's funny about those meds. They only work when you take them like they're supposed to be taken. And we have to do a little better job of getting that to work. DMAS, the state, we're doing our part in trying to align what we're asking for with what you will be asking for. Regional population health initiatives. As Marilyn says, we can't solve everything from Washington, and I don't think we can solve everything from Richmond. And regions of the state will have their own unique issues. In Southwest Virginia, I hear about prescription drug diversion and substance abuse. We have pockets where perhaps diabetes is a bigger problem. We have diseases of affluence and poverty, such as obesity in different areas. So we have to look regionally at what public health initiatives need to be in place. Value-based insurance design, we've talked about. And then finally, knowing your choices. Can people choose wisely? Let's not go in and demand stuff that doesn't work or is not needed. Let's use the emergency room for emergencies. How do we encourage that? And then I want to talk just for a minute about advanced care planning, advanced directives. We all hear, and I hear it all the time, Secretary Hazel, but isn't it true that all this money is spent at the end of the life? Ladies and gentlemen, it is true. But do you want me as a bureaucrat or my colleagues in the legislature to make those decisions for you, or do you all want to plan ahead and make them for yourselves?